Welcome to CHD Unpacked, a podcast about living with congenital heart disease, brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we will be unpacking the topic of congenital heart disease and exercise. We are very honored to be joined by today's guest, Dr. Patricia Longmuir. Dr. Longmuir is a senior scientist in the Healthy Active Living and Obesity Research Group at the Children's Hospital of Eastern Ontario Research Institute, and a professor in the Faculties of Medicine and Health Sciences at the University of Ottawa. Dr. Longmuir's research interests are the promotion of physical activity to children with medical conditions and disabilities, and the use of physical activity to prevent and/or treat morbidity. Her undergraduate, master's, and PhD theses examine the impact of interventions to increase physical activity among children with heart defects or cystic fibrosis. Dr. Longmuir's postdoctoral fellowship was a community health promotion initiative targeting parents of young children. Dr. Longmuir has published more than 100 papers and 6 book chapters in peer-reviewed literature. She has delivered over 220 scholarly conference presentations and more than 90 invited and keynote addresses. Please join me in welcoming Dr. Patricia Longmuir. Hi, welcome Dr. Longmuir. Thank you so much for joining us today.
I'm glad to be here, Amanda.
So I think we'll jump right into it. So this episode, we're going to be talking about congenital heart disease and exercise. And can you just start off by telling us a little bit about the scope of your practice and the research that you do?
Okay, so I am a registered kinesiologist by profession and also a PhD scientist at the Children's Hospital of Eastern Ontario in Ottawa. And my research program focuses on enabling children with medical conditions like congenital heart disease to participate in physical activity with their friends. And because we know that physical activity is critically important for quality of life in young children, so I do research with children and teens and babies, all different ages, but I primarily focus on the younger kids to try and develop active lifestyle habits before they get into other things.
Great, thanks so much for explaining that to us. And would you mind just giving us an overview on how you describe exercise versus physical activity?
Well, physical activity is any physical movement of the body where you're moving around, moving your arms, moving your legs, moving from place to place. Whereas exercise is usually, we think of something that's more structured and planned, and it's usually designed to improve physical fitness. So, if you're going to the gym to work out, or you're going for a run, or you're doing something specific to improve your strength or your flexibility, or your endurance, then that would be considered exercise. But physical activity includes exercise, but it also includes, carrying the grocery bags and shoveling the driveway and all the other physically active things that we do.
Thank you. I think that's a really important distinction to make in this discussion because it might not be well known, the distinction between those two terms, and I think it's important to highlight both of them. And so in the context of congenital heart disease, can you maybe touch upon what your research or research in general describes in terms of the levels of physical activity in children with congenital heart disease as compared to their peers?
Right, so the well, first of all, I'll say overall, we know that children in general, all children as a group, are not as active as would be preferable for optimal health and growth and development. So we know in the general population, there's about a third or about 30% of children who meet the current recommendations for physical activity every day. And within that 30% that meet the recommendation, there's a small percentage, less than 10% of children who are active every single day, not just on average, but they're active every day. And what we know about children with congenital heart disease is that there's similarly a small group, less than 10%, who are very active every day. And, they get the 60 minutes every day and they have very active lifestyles. They're involved in sports, so they're involved in physical activity in their leisure time a lot. And so those kids are very active. There's also, about 30% of the kids who with congenital heart disease who are relatively active, but they're not quite as active as their peers. So where their peers are doing on average 60 minutes a day, kids with congenital heart disease tend to do about 50 minutes a day, which doesn't seem like a lot. It's 10 minutes a day, but it's a 20% difference. And the health benefits or the health consequences of that difference we think are quite important. And then of course the majority of kids with congenital heart disease or without congenital heart disease are not active enough, and they're only doing about 40 minutes a day. We really need to increase the activity level of those children by about 50%, which is a huge change to try and initiate to get up to what would be recommended for optimal health outcomes.
That's a really important statistic to keep in mind in terms of the fact that children in general aren't making those thresholds that are recommended. Do you have any specific recommendations that you give to families in terms of trying to make maybe marginal increases in physical activity that can then, with consistency, have that kind of difference in the future for them?
Yeah, I mean, what I usually try and emphasize for families is that, it's not an all or nothing thing. Mm-hmm. So the 60 minutes a day is what the World Health Organization recommends for children from 5 years of age to 17. So children and teens. For younger kids, it's 180 minutes a day for the preschool age group. But it's not all or nothing. So it's not either you do 60 minutes or you don't get any health benefits. The biggest bang for your buck, so to speak, the biggest benefit you get is from taking a child who is relatively inactive and getting them to do a little bit of activity that pays off in very substantial health benefits. If you take one of those children that I mentioned who's already very active and doing 60 minutes a day and you add more activity into their lifestyle, they might enjoy it and they might be doing things that they like, but the health benefits you gain from that change for that child who's already active are relatively small compared to getting, the couch potato off the couch and even moving for 5 or 10 minutes a day.
Okay, thank you for clarifying that piece. And in congenital heart disease specifically, there might be some cases where exercise restriction is indicated. Can you touch upon maybe specific types of congenital heart disease where you would be a little bit more cautious about exercise restriction versus others that typically don't tend to have those types of restrictions?
Yeah, so it's despite what people expect, it's not really tied to the actual diagnosis, the congenital heart disease diagnosis. Because there's so much difference between, one child with a coarctation and another one with a coarctation, or one with a Fontan or another one with a Fontan. Mm-hmm. What it really comes down to is the individual child's heart and the way their heart functions. So the big flags, I guess, for potential exercise restrictions are if the child has arrhythmias, so irregular heartbeats that occur during exercise. So a lot of people will have arrhythmias when they're just walking around, but when they start to exercise or they go for a run, the arrhythmias disappear. Other people don't have them kind of walking around or sitting around, but they start when they're exercising. And it's the ones that appear during exercise that we may want to look at the types of activities they're involved in. It's not that they can't be active, but we just need to consider what types of activities are appropriate. Also for kids with ventricular dysfunction, so if the cardiac muscle itself of the ventricle is not working properly, then some activities are recommended and others are not. Similarly, if there's any history of fainting, obviously certain activities that, horseback riding and rock climbing and stuff, if there's a history of fainting, are not things that we would recommend. And similarly, children who are on anticoagulation or who have implanted devices, there's restrictions on the body contact that they can endure during physical activities. So things like kickboxing or ice hockey with body checking are not recommended, but there's still in all of those cases, there's lots of other things that kids can do. They just have to be a little more careful in terms of selecting appropriate activities.
That makes a lot of sense. Is there an approach that you have in terms of screening modalities that are utilized in order to better inform which exercises or forms of physical activity would be best for a child?
I actually, when talking with kids and their families, really base it mostly on what they're interested in. Unlike adults who will force themselves to go into the gym or, go and work out because, their uncle had a heart attack and they want to make sure it doesn't happen to them or whatever. Kids don't generally do that. They do what's fun. And even teenagers, even at teenagers, they tend to think of themselves as invincible. So the whole I'm doing it for my health later thing doesn't carry as much weight. But what's important is being with their friends, having fun, doing things that they enjoy. And so I usually start from there with families and figure out a way for the kids to be able to do the activities that they find enjoyable and that they can do with their friends and that they can be successful at with their friends. And sometimes that takes a little bit of investigation, I guess, or it takes an opportunity to build up the child's fitness or the child's skills if they haven't learned an activity. Often kids with CHD, they've had surgery when they're younger, and so they haven't had as much time to go out and play and learn to bounce a basketball or what have you. So sometimes starting with activities that are not as common among their friends can be helpful so that they and their friends are both learning a new activity together.
Are there non-medical barriers to exercise that you've noticed children with CHD tend to face?
Yes, I would say that the non-medical barriers are the biggest barriers to physical activity for children and adults with congenital heart disease. We've done a lot of work, and that we've done and that other people have done, showing that even those with the most complex forms of congenital heart disease, like single ventricle, can participate in exercise, can be involved in sports, and can be quite fit relative to their peers. But it's the non-physiological barriers that really seem to determine whether or not the children are active, more so than their particular anatomy or the particular shape of their heart. And for me, the one that pops out most frequently is confidence. So the child's confidence in their ability to participate, they have to want to participate, but they also, part of that wanting to participate is wanting to be successful, not necessarily winning all the time, but you don't want to be the one that the other kids are laughing at, or you don't want to be the last one picked for the team, right? You want to think you have a chance for success. So you have to be confident in your own ability, and equally the confidence of parents and others is equally important. Parents have to be confident about what's appropriate for their child. Teachers have to be confident about what's appropriate for the students in their class. Coaches that are running recreation leagues and swimming instructors, et cetera, they all have to be confident in that the activity is appropriate and the child can participate, because if they're not confident, it's the natural human reaction to shy away from things or to prevent participation, right? Even if I don't have my own child, but I'm looking after someone else's child, and if I think, oh, maybe that's not safe for them, I'm not going to allow them to do it, right? So really everybody in the child's world has to be confident about what activities are appropriate for the child and confident that the child can participate.
That makes a lot of sense. Do you find that in people with CHD, whether they're children or adults, if they've received more education and have more kind of autonomy over their healthcare, that translates into more confidence in terms of their exercise and their willingness to do so?
Yes, I would say so. Although I think one of the biggest barriers that I hear about from patients and families is that the information they've gotten about exercise often doesn't make sense to them, or doesn't make sense within their life experience. So within the way they live their lives, or within the setting that they live. And so it's hard sometimes for them to feel confident, because they're not entirely sure they don't entirely understand the information that they were given. So often, healthcare professionals tend to focus on what you can't do. So they'll know very clearly, I'm not allowed to do this, and this, because that's what the doctor told me. But the doctor didn't say anything about this. So the doctor told me I can't play on a hockey team, but the doctor didn't say anything about whether I can play floor hockey and gym at school. But it's hockey, but it's not the same. It's not on a team, and so it leaves them with questions. It's like, well, is floor hockey and during gym okay or not okay? And obviously healthcare professionals can't go through every possible scenario of physical activity and say yes or no. So it really comes down to patients and parents being able to understand the reasons for the restrictions, if there are any, so that they can then translate that, into other settings. So, for example, I had one family, the child was on anticoagulation, and they knew that they couldn't do a lot of body contact sports, and the child was very active and very fit, but all in in cycling and things that were safe for them to do. And then they went on vacation and they were swimming with dolphins, and so they let their child swim with dolphins, and he fell against the dolphin and ended up with a very severe bleed in his legs, and that's not anything that their doctor ever would have said. Now, don't go swimming with dolphins, right? But it was just another situation where a kid went tubing was at a cottage and went tubing, and the parents didn't realize the impact of bouncing on the tubing, and it resulted in a severe bleed. So I think it's just often we don't give enough background in terms of why the restrictions are necessary and how to apply them, or how to get around them, or what to think about when you encounter a new activity. How should I evaluate it to see whether or not it's safe? We tend to just sort of say, all of the published guidelines that we use say, yes, you can do, golf, billiards, ping pong, but you can't do soccer, tennis, cross-country skiing, downhill skiing, or whatever. They're all very sport-based. And there's so many other types of physical activity that kids do that aren't specifically a sport. They go to swim at the local swimming pool in the summer, or they go to summer camp and they're playing tag or cooperative games or something. And there aren't guidelines for any of those types of activities, so it's hard for for patients and families to make decisions sometimes about what's appropriate.
Yeah. Do you feel that there's a lack of knowledge translation out there for individuals with CHD and their families? Are there resources that people can turn to in order to get some of this information? Because they might not be able to see their healthcare practitioner as frequently as maybe they'd like to, or questions arise at inconvenient times. So are there ways where people can address their questions?
Well, there definitely are. I mean, obviously, if you can talk to your healthcare team, that's the preferred option. But remember, your healthcare team isn't just the pediatric cardiologist, right? It's also the nurse in the clinic, but it's also your family doctor if you have one, or the nurse practitioner. So there's a number of options. It doesn't necessarily have to always be the pediatric cardiologist or the cardiac surgeon, for instance. Mm-hmm. But we have been working on developing some resources that provide information about physical activity for those with CHD, and we've tested them out in a number of different clinics across Canada. We're in the process of making those available. They'll be up on the CCHA website in the next iteration as it gets revamped, and they will also be up on our CHEO website under parent resources. And they're really just most of the resources that we developed were checklists of what children can do, to say you can do this and you can do this and you can do these types of activities, and that hopefully will give families more confidence for themselves, and when they're interacting with swimming instructors or phys ed teachers at school or whatever, they actually have something in writing from the physician that says, yeah, okay, check, volleyball's okay, or playing on the playground monkey bars is okay, to hopefully build that confidence.
Yeah, that's great that those resources are available and becoming more comprehensive as well. And I think it also gives people with CHD an opportunity to maybe question the reasons behind the recommendations a little bit more deeply as they get older and as they're able to understand their condition a little bit more. And then they're able to have those conversations with other people in their lives, like coaches or other adults that they might be interacting with for physical activity or for exercise. But in people with CHD that haven't kind of reached that level of understanding or are still kind of struggling to comprehend the reasons behind certain recommendations, do you have any advice for an approach that they can maybe take to speaking to a coach or someone that might be instructing them about certain physical activities, just so that they can stay safe, but the person providing the instruction also understands the scope of this person's condition appropriately?
Yeah, I mean, it's hard to make an overall recommendation that would apply to everyone, of course, but in general, I tell people to use the talk test. So the talk test is that you can exercise as much as you can, but while you can still carry on a conversation. So you can still talk to somebody. So we know that if you do that, if you're exercising and doing as much physical activity as you can, but you can still talk, you'll be in the zone where your fitness will improve. So you're in the right area for the intensity of the physical activity. If you get to the point where you can't talk and you're panting and you can only get a word out here, there, or the other word, that's actually beyond what we need to do for health and fitness reasons. If you're involved in elite sport, there's reasons to get that fatigued, for coaching and stuff, but for people in general who just want a healthy lifestyle and want to be active with their friends, you don't need to get so out of breath that you can't carry on a conversation. So as long as you can carry on a conversation, do as much as you can. And often I find that coaches can understand that. You know, you don't necessarily have to tell them about a heart condition or whatever. They don't have to understand it, but they may just need an explanation to say, you know, I have a condition, or for whatever reasons, or I'm, you know, because I haven't done this activity before, I'm getting really out of breath and I can't carry on a conversation. And for me, I'm more comfortable if I stay at a level where I can carry a conversation. And most, I think, teachers or coaches would accept that or support that, because the talk test it's not something specific to CHD. Doing that, I think, is the best way to get started. If you're talking about wanting to get started, if you're not active or you're wanting to increase your activity, just try and do as much activity as you can when you're active. Walk as quickly as you can, or ride your bike as up a hill if you can, or whatever, but make sure that you continue to carry on a conversation while you're doing it. And for almost everybody, that will be a safe amount of physical activity, and also give them some of the fitness and health benefits of increasing their physical activity.
Thank you. I think that's a really useful rule of thumb that everyone can apply, and is very easily translatable to coaches or anyone else that they're participating with. And something else I was wondering is there any evidence to suggest that children with CHD that are more active children have better outcomes in terms of the condition of their congenital heart disease when they're adults?
No, there really isn't. And the reason is not that it's not a relationship, it's just because of the complexity of doing that kind of research. We know very clearly adults who are more active have better health outcomes, because you can follow an adult from 30 years old to 50 years old, and there won't be huge changes in their lifestyle. They finished growing and developing and stuff, so things are relatively stable over that time period. And there's good research to show that those who are more active have, less heart disease, are less likely to get some forms of cancer, are less likely to have depression and anxiety, lots of different health outcomes that are associated with an active lifestyle. But for kids, first of all, their bodies are still growing, right? So they're growing and developing. So what was a strenuous activity when you were younger, by the time you get to be an adult, you're stronger and you have more endurance than you did as a kid. So if you're just doing the same activities that you did when you were a kid as an adult, you're not getting the same exercise training benefits or fitness benefits. Plus, kids' lifestyles are entirely different from what their lifestyles will be as adults. They're in school during the day, but they're not coming home after a day at work, making dinner, putting the kids to bed, going to bed themselves, etc. Their lifestyles are quite different when they're in school. They have physical activity breaks, they have lunchtime, they have recess, they have physical education. And so there's really so many factors that change between when you're a child and when you're 50 years old, that it's research that everybody would like to do, but nobody's really figured out how to do it and track all those other pieces of when they started swimming lessons, or when they learned to do this, or when they learned to do that, or when they, as they progress through childhood, it's very difficult.
Yeah, I think that's similar to a lot of areas of research in pediatrics in general. Just it's really difficult to do these studies, whether it's in terms of practical things like exercise or physical activity, or in terms of, trialing a new medication, comes with more strict ethical guidelines as well. So, I mean, it's good to know that, these limitations in knowledge are based on the fact that it's difficult to do the studies, but just overall keeping just a general mindset of engaging in physical activity that follows the guidelines that are currently out there, I think is probably a safe overall recommendation. Would you agree?
Yeah, I would agree. And the guidelines, it's not that the guidelines aren't based on research, they are, but it's not tied to the long-term health outcomes necessarily that we think of as adults. So it's not, a reduced heart disease or reduced incidence of high blood pressure, diabetes, or cancer, or whatever, which occur later in life. There's lots of benefits of physical activity for children during childhood. Mm-hmm. So we know, for instance, that physical activity is actually essential for normal growth and development. So if you ever see a child who has been paralyzed, for instance, at a young age, they grow up to be adults, but their legs are very short. And that's because the bones in your legs don't grow unless you're walking on them and weight bearing on them and using them for physical activity. So we know that, there's lots of examples of connections in the brain that develop during childhood through physical activity. The brain actually makes those connections during physical activity in childhood. And most importantly, physical activity is how children socialize. It's how they develop their relationships with peers. If you think about all the birthday parties your child gets invited to, they're often, skating parties or swimming parties or bowling parties or what have you, right? So physical activity is the way children learn to interact with peers and to socialize with peers. It's how they learn about things like cooperation and collaboration and friendships and that type of thing. There's also really good evidence that physical activity in childhood actually enhances children's ability to learn academically in school. So we know that if you replace an hour of their classroom time with an hour of fairly vigorous physical activity, that their grades in school will actually will improve, even though they're spending an hour a day less in the class. They're spending 5 hours a day in the classroom instead of 6 hours a day. Their grades and their learning of academic material actually improves. So there's lots of benefits to physical activity during childhood, and it's that research that the guidelines are based on. So the guidelines are based on research knowledge. It's just not research that shows the connection between childhood physical activity and long-term health outcomes that would happen in adulthood.
Thank you for making that distinction. I think it's important to recognize, the here and now, and how can my actions impact how my health is going to be influenced on a day-to-day basis, and the social aspects as well, like you were mentioning, and those are not something that should be diminished also, because that also has a very close tie to the mental health of children, which is really important as well. Just as kind of a closing question for you, for someone with CHD that was receiving pediatric care and is now transitioning into adulthood, typically we see that there's less resources for adults, and it's much more onus is placed on the individual to advocate for themselves. Do you have any advice for someone in that position in the context of exercise and physical activity, just some ways that they can advocate for themselves when they're going through that big transition in their care?
Yeah, and it definitely is a big transition, and what I wouldn't recommend in most cases is to try and do that transition with also at the same time making a big change in your lifestyle habits. Mm-hmm. You probably want to get through the transition from pediatric to adult care, and then when you've sort of managed to navigate those couple of years at least, then start to look at changes to your lifestyle once your adult lifestyle is sort of established. Not for everybody, but for most people, I think it would be too overwhelming to try and do the two at the same time. But I think, starting small, starting realistic. So there's an acronym SMART, which you can Google, SMART goals, but making goals that are specific and realistic and suit the amount of time you actually have available, and that are things that you can achieve. So if, deciding for yourself, maybe you want to build more physical activity into your day-to-day life. So things like, getting off the bus one stop early and walking the last couple of blocks to work, or parking the car at the far end of the parking lot and walking into the mall from there instead of parking as close as possible, or going up one flight of stairs instead of waiting for the elevator, or carrying your groceries to the car as opposed to wheeling them straight to your car in a buggy. There's lots of little things that you can do to build some physical activity into your day-to-day without actually having to formally exercise or commit big blocks of time. Using the talk test is very helpful as well. If you are walking somewhere, try and walk as quickly as you can while you can still talk and carry on a conversation, as opposed to sauntering along. You can build a little bit of activity in that way. And the other thing to keep in mind is that there is very good research showing that you don't have to do. So for adults, the recommendation is 30 minutes a day, 5 days a week. So 150 minutes a week of physical activity. But there's very good research showing that you don't have to do 30 minutes all at once. You can do little pieces, even as short as 2 or 3 minutes at a time. And if you accumulate, if you do 10 3-minute sessions in a day, that's your 30 minutes, and you'll get the health benefits the same as if you went and did a 30-minute workout in the gym. So, if you're finished eating your lunch and you can go for a walk for 10 minutes, that's a third of the physical activity that you already need for the day. So that's what I mean about thinking about it realistically, what you can actually fit into your day. So being realistic and patient with yourself, and saying, realistically, what can I fit into my life, and recognizing that every little 2 or 3 minute bit you can put into your life provides you with benefits. It doesn't have to be a massive change, and you don't have to do the 30 minutes a day, as I said earlier, to get the health benefits. Just doing an extra 2 or 3 minutes a day will give you extra health benefits, both immediately and in the long term.
Thank you so much for sharing that and giving us some practical advice on how to approach these kinds of situations. And that's all the time that we have for today. Thank you so much for joining us and providing your expertise. From everyone at the CCHA, we really appreciate you contributing to this initiative.
Happy to have had the chance to chat with you. It's been lovely. Thank you.
Thanks so much.